All right, good Sunday afternoon, everybody. Let's go ahead and talk about cutaneous disorders. So we're talking about disorders of the skin and the soft tissue, the connective tissues, the epithelial tissues, all that good stuff that comprises your skin. All right, so this is just going to be an introductory lesson over the anatomical process or anatomical parts of your skin. Yay, fun. All right, cool. So, review of anatomy. So let's talk about it. Your cutaneous system is the largest organ of your body, and it functions to protect you from antigens and pathogens. It also functions to assist you with temperature regulation via sweating and things of that nature. Also, storage of things such as keratin and melanocytes and a lot of other things. And also, it takes place in sensation with our afferent nerves. So let's go ahead and dive right in. Let's talk about, first off, where this picture came from. It is copyright 2014 Pearson Education. So that's out of the way. Now let's talk about the three primary layers that I want to discuss today. We're going to talk about the epidermis right there inside the red box. So if you're listening to this in your vehicle, you can pull it up on YouTube when you get home and look at the pictures. I like pictures. I like drawings. And then dermis. So epidermis is the outermost layer, and we will break that down even further here shortly. There are 4 layers that I want to discuss. The dermis, also known as the papillary and reticular layers, we'll discuss those principles as well. And then the third layer is the hypodermis. So with all my ADHD babble in between, our outermost layer is the epidermis, the middle layer is the dermis, and then the innermost layer, also known as subcutaneous, is the hypodermis. So, briefly, get to the point. Epidermis, we have 4 layers of different types of tissues. We don't have any blood vessels present in there. So keep that in mind once we get into trauma and things of that nature. Once you get into the dermis, you have capillaries in there. So you have reticular tissue, you have a bunch of connective tissue, you also have hair follicles, you have shafts, you have nerve endings, and you also have capillaries. In the hypodermis, that's whenever you start to have larger blood vessels, particularly the cutaneous plexus. So, with that to say, you have larger not arteries, but arterioles and larger venules in there. And you also have adipose tissue. Cool, so let's move on. So the epidermis, we have 4 primary layers, as I discussed earlier, but the outermost layer is the epidermis. So let's talk about what the epidermis does for you. So it holds keratinocytes, or keratinocytes, or keratinocytes. So what do those do? Those assist in the actual pigmentation of your skin, and they also they take part in the absorption of vitamin D and things of that nature. So the epidermis will protect us from the environmental conditions such as cold, heat, sun. Also, it prevents us from becoming infected by different antigens and different microorganisms. So let's talk about the layers of the epidermis. This photo comes to you via copyright 2006 Pearson Education. Cool, out of the way. It is actually, so this photo, I do want to say, comes out of Marieb and Owen Anatomy and Physiology. It's a great book. It is my preference for A&P books. There are a slew of different versions. However, this one came out of the 6th edition, I believe, 2006. So, let's talk about the 4 layers that I want you to know. You have the outermost layer, which is pretty much, for a lack of a better term, these are dead cells that are stacked on top of each other. That is called the stratum corneum. So the stratum corneum, that is the outermost layer. It has a lot of dead cells stacked on top of it. Next, we have the stratum granulosum. So these are cells that have organelles inside of them, but they are deteriorating. So these are cells that are dying. So with that to say, we have a lot of granules being released inside of these, specifically lipids. Also, we have particulates of keratinized substances that will assist in the pigmentation of skin and also the absorption of certain things. As we move on down, the third layer of the epidermis, we have the stratum spinosum, and then the fourth and final layer, which borders the dermis, and you can know that because you think basal. So think of the basilar layer. So this is where the nerve endings will actually make contact with the epidermis. This is called the stratum basal or basale. All right, so the four layers in review. Outermost layer is the stratum corneum. The next is the stratum granulosum. The next is stratum spinosum, and the fourth and final layer of the epidermis is the stratum basale. I like basil. Dermis. So let's move on to the layers of the dermis and let's talk about what it does. So the dermis holds collagen fibers. It also holds hair follicles, some glands, and again, this is where we have capillaries. So again, dermis. We're going to separate this into the papillary layer and the reticular layer. Therefore, why is this important? All right, so if you get an abrasion, and I'm kind of fast forwarding to trauma a little bit, guys, but if you have an abrasion, you're bleeding, that means that you have gone past the epidermal layer. You are now into the dermis, because over here on the right side of the screen, you'll see we have capillaries, which have blood, which if they are disrupted, blood leaks out. So, all right, moving on. So we have the papillary layer. It contains papillae and capillaries and sensory neurons. The reticular layer. So whenever we talk about reticulum, it is a substance to hold things together. So we have collagen fiber bundles that move up and down, and then we also have connective tissue proper and elastic fibers that will go left and right, and so therefore that makes up this reticulum to where things can sit without having to be fluid and move around. So let's move on down to the subcutaneous layer, or the hypodermis. If you're watching the video, I totally forgot to type in adipose tissue, so I apologize. But subcutaneous, hypodermis, this is where we have a lot of the padding. This is our final layer of protection before we get down into the muscle. So, and again, we have the subcutaneous plexus that has larger blood vessels, such as larger venules and larger capillaries in here. Or excuse me, larger venules and larger arterioles. So, again, there's the cutaneous plexus, and there is some adipose tissue with the picture. All right, so that's our that is our review of anatomy. So let's go ahead and talk about the types of lesions. So what is a lesion? So a lesion is a break in the continuity of the skin. And I want to break this down into two different kinds of lesions. You have primary lesions and secondary lesions. Apply the same principle that you apply to CVAs and strokes. You have primary injury versus secondary injury. A primary injury is the direct result of the disease process. And examples that you can think of are macules or papules, and we'll talk about those shortly. However, secondary lesions result from the development of a primary lesion and its after effects, or they are also products of external trauma. So examples are scales and ulcers. These may develop from primary lesions or primary injuries. So external trauma, example, scratching. So if you're scratching and you develop scales and you develop other types of lesions, those are secondary to the initial injury itself, which is you scratching. So let's move on. Let's go ahead and let's discuss primary lesions. So as we move in, I want to talk about how you describe a lesion. This needs to be given in your patient care report, in your narrative, and it also needs to be given whenever you're calling in report to the hospital, or at least whenever you get there. So things to keep in mind whenever you're describing these lesions, you can talk about the size, the color, the type, the arrangement, distribution, shape, the moisture of it, and the elevation of it. So let me break those down a little further. Size, we're going to talk about it in millimeters. Okay, so if you don't carry a ruler on your ambulance, man, you can get one for 50 cents at a dollar store. Why is that important? Because, well, let's say that you are transporting to a trauma center with a significant injury, and you need to estimate the size of the size of the injury, or if you want to be even more accurate in your documentation of your narrative, all you have to do is just hold a ruler up to it, look at how many millimeters it is. There you go. Color. So the color refers to the pigmentation. So literally, what color is it? Type. Is this a primary lesion or is this a secondary lesion? Arrangement. So is there a group of lesions, or is this one lesion all by itself? This becomes important when we start talking about things like melanomas and skin cancers. We'll talk about that in the next lesson. Distribution. Is it truncal or is it generalized? Shape. Is it round or does it have irregular borders? So when we talk about that, whenever I say, is it perfectly round? So think about moles versus melanocytes, or moles versus malignant melanomas. So if we have a good round mole with no disruptive border, that can be normal. However, if you have an irregular border and it doesn't have any normal margins, then you want to be concerned about that. Moisture. Is it bleeding? Is it moist? Or is it dry? Elevation. Is it flat or is it raised? All right, so let's talk about a few of these. Let's start off with a macule. Here you have some pictures that will describe what a macule is. It is circumscribed in color and it is flat. So it is less than 1 centimeter as well. And there are different types of macules that we will discuss when we get into different specific types of skin disorders. So if you're listening to this in your vehicle, this is the point to where I would highly recommend that you watch it so that you can see the pictures of everything's. Everything's? How about everything? All right. So a patch. A patch is a large macule. So something that you can relate that to is a Mongolian spot. So this picture is a little, it's kind of bright, but you can see the spot or the disruption in the different colors. So it's a flat, circumscribed, discolored lesion. And these are going to be greater than 1 centimeter in diameter. So it's a large macule. And again, the biggest example to utilize is a Mongolian spot. Papules. Papules are elevated, solid lesions. They can be any color, and they arise from the epidermis. All right. So here, and this is common, especially people who have a lot of freckles. So this is an example of one here. Looks like the outer edge of a nair. So there you go. So let's move on to plaque. So plaque, you can deal with a lot of this during psoriasis and some other forms, but plaque is an elevated, solid lesion, and it lacks a deep component. So you don't see any fissures formed in it, and we'll talk about fissures here in a little bit, but it is formed by a coalescence of papules. So again, let's go back to a papule. Here, you have an elevated, solid lesion. It's one by itself. However, a collection of these is plaque. So, moving on. A nodule or a nodule. So this is an elevated solid lesion. Okay, so as you can see in the little illustration here, it goes deeper than the epidermis. You are technically in the hypodermis at this point, or within the subcutaneous tissues. Now it can be only within the dermis. However, they are larger and they are deeper than papules. All right, a wheal. What? So a wheal, this is a firm, rounded, flat-topped elevation of skin. And typically they are pruritic. So they itch and they look like a rash. This is technically what you would medically appropriate, or appropriately medical language, you would describe a rash as a wheal. What? Okay, moving on. Vesicles. So, vesicles are elevated lesions that contain fluid. And specifically, the difference between a pustule and a vesicle is going to contain clear fluid. Here we have an example, and here we have an illustration. So, a bulla. So, a bulla is going to be similar to a blister, and they are localized. So it's localized to the site of infection or trauma, and it is a fluid-filled lesion, and it may raise up a little higher than that of a vesicle. So, and the primary difference between a bulla and a vesicle, vesicles are going to be a lot smaller in diameter. So we have larger bulla here. Again, they look similar to a blister, and whenever they pop, we'll talk here shortly about what you call that type of injury. And again, like I was saying earlier, you have a pustule. So a pustule is a fluid-filled lesion that contains this word sucks, and I suck because I can't say it. Purulent material. So this can be, it's not technically a cyst, but you can kind of think of acne as an example, but it's not really the same. So this is how cysts may be able to form, though. So if you have a raised lesion that is filled full of purulent fluid, then it is a pustule. A cyst. So a cyst is an elevated, circumscribed, therefore it's walled off. All right. So it's an elevated cavity that is filled full of fluid or purulent material. Those can spread depending on the cause, and we'll talk about that here in a little bit. All right. So secondary lesions. Secondary lesions are due to or secondary to either a primary lesion or trauma. So these come after the primary lesion. And again, whenever you're describing these in your narrative, I do want you to document the size of them, the color, the type, whether it's primary or secondary, the arrangement, the distribution, the shape of it, the moisture, and the elevation. So if somebody can come up with a really cool mnemonic for that I would be able to tell a middle schooler. Don't be perverted and don't be nasty about it. All right, so I just said nasty. That was weird. Crust. Yeah, right into crust. Let's just go there. So crust is a collection of cellular debris or dried blood. So this is secondary to a lesion that has already occurred. It can be secondary to trauma, or it can be secondary to an open sore or lesion that has already occurred. So, erosion. So this is a partial focal epidermis loss. So whenever I was talking about if a bulla were to burst, or if you had a blister that was going to burst, this is typically what's left over. You have a depressed and moist, eroded spot of skin. So it typically will only involve that of the epidermis. All right, excoriation. So this is what you get from scratching. You have linear erosion from the scratching, and sometimes it'll be crusted over depending on how deep and how much bleeding there was. But this is a hollowed out area, and this, like you can see here, it looks like road rash. It looks like a nasty abrasion. However, there are only certain spots where where the patient got down into the dermis. All right, so ulcers, and we're going to talk about decubitus ulcers and the different grades in the next video, but let's talk about what they are. So ulcers are full thickness craters, which means, and don't associate that with burns necessarily, because a full thickness burn goes all the way down to the skin, or excuse me, all the way down to the bone. Now, there are some decubitus ulcers that do that, but an ulcer is a full thickness crater involving the dermis, the epidermis, and the surface. So, the surface of the epithelium. So it can be depressed and it may bleed. One of the big things to remember is the skin is not intact. Therefore, this patient is even more susceptible to bacterial infection. So let's talk about the cause of these secondary lesions. So they can result from trauma or bacterial infection, or a certain condition such as any type of diabetic disorder or neuropathy involving peripheral arteries and veins. So lesions are deep and they are irregular, or the ulcerous lesions are deep and irregular in shape, and they may bleed, and ultimately they probably will leave a scar. Pressure sores or decubitus ulcers or cankers are examples. So whenever we talk about decubitus ulcers, let's think of the geriatric population. So if they are bedbound and or let's say if we put them on a backboard, you can technically cause a grade 1 ulcer on a long transport due to a backboard. So we'll talk about that in the next slide. A fissure. So a fissure is where the epidermis, or the outermost layer, has vertical loss and you have sharply defined walls. So here I want you to think about athlete's foot. That's going to be the primary example that we have here. It's drying it out, and you see, again, a sharp defined wall. Scars. So scars are secondary to the healing process of a previous lesion or previous trauma. So you have a collection of hypertrophic connective tissue that is growing on top of each other. So it implies previous dermoepidermal damage. So keep that in mind as you're doing your assessment. And again, these are going to be predominant in large areas, such as if somebody were to have cardiothoracic surgery or abdominal surgery. All right. Scales. So scales are thick stratum corneum, and it's a hyperproliferation or increased cohesion of keratinocytes, or keratinocytes. So again, you think of the keratin that's within the epidermis of your skin. So this is those clumping together. So examples where this happens are down here at the bottom, where we have psoriasis, and we also have eczema. So this is a severe form of eczema. All right, so that's it for this video. Go ahead and watch the next part of medical cutaneous disorders, where we talk about specific illnesses and diseases. All right, thanks.